So let's get started with this. So we'll start with the first clinical vignette, the first case that we have got here. So we want to discuss it. First, we want to discuss the practical aspect of it, the clinical aspect of it, and then we will match it with the corresponding drugs also. Right. So the first one, the clinical vignette, 54-year-old obese female. So there is a 54-year-old obese female who has come with a history of uncontrolled diabetes since the past 6 years. So she's 50 plus, postmenopausal, she's having a obesity. So risk factors we must read. So whenever you look at the age epidemiology, you are adding to the risk factors. So postmenopausal, she's obese, she's uncontrolled diabetes. She has presented to the ER with the complaint of chest pain. So she has come to the ER with the complaint of the chest pain. So points we will discuss here. So in this question, we want to discuss the approach to the chest pain. So it is not just about answering this question. It is also about discussing the entire topic here. Complaints of chest pain. The pain was over the precordium associated with the Levine's sign, and the pain started 2 days ago and worsens after activity. The ECG shows non-specific ST segment changes and the troponin was negative. So the ECG shows non-specific ST segment changes and the troponin levels were negative. So which of the following are indicated in the treatment of the patient except? So I would like all of you to tell me what is the diagnosis and what is the correct answer. I want you to give me what is the diagnosis in this case and what is the correct answer. I want you to type and then we can discuss this question in little more clinical detail. So what would be the diagnosis based on the clinical history and the laboratory findings given to you? And which of the following are indicated in this treatment except? Come on. So start typing. When we start reading the next clinical vignette only, I would want you to go through that and tell me diagnosis and which of the following are not included in the treatment of this patient. I'm just waiting for a couple of answers for you to start. A 54-year-old obese female, uncontrolled DM 6 years, presented to ER with complaints of chest pain. Right. So till you all type, let me discuss the approach to chest pain. So how common is chest pain? As I told you in the class we discussed, chest pain is the number 3 symptom in the emergency room. It is the number 3 symptom in the emergency room. It is the number 3 symptom in the emergency room. Number 3 symptom in the emergency room is the chest pain. Is the chest pain. But please remember the most common cause of the chest pain. The most common cause is gastric. The most common cause is gastric, but the most dreaded cause is the cardiac. Most dreaded cause is cardiac. I'm reading your answers. You keep typing. The dreaded cause of the chest pain in the ER is the cardiac cause of the chest pain. Is the cardiac cause of the chest pain. Is the dreaded cause. It is the dreaded cause. So tell me, so what is the causes of cardiac chest pain? What are the causes of cardiac chest pain? Like I teach you that every time when you get a symptom of chest pain, what are the points you want to look for? You want to look for the site of the pain. You want to look for the site of the pain. You want to look for the character of the pain. You want to look for the character of the pain. You want to look for the radiation if present. You want to look for the radiation if present. And we want to write down the final diagnosis. And the final diagnosis. So clinically, I want you to give me the answer. What are the different cardiac causes of chest pain? What are the different cardiac causes of the chest pain? Yes, the most common is the classical angina. Yes, the most common cause is the classical angina, is the most common cause of the cardiac chest pain. But let's not forget, chest pain can occur also in cases of aortic dissection. In the emergency, aortic dissection can also mimic myocardial infarction, and it can be also because of the pericarditis, of the acute pericarditis. So we have got different cardiac causes of chest pain. We have got different cardiac causes of chest pain. So we want to know how to approach to the chest pain. So in the emergency, chest pain is a common symptom, but the most common cause is gastric, but that's not dangerous. When we talk of ER, we are always looking at the dreaded cause of the chest pain, and that is cardiac. So how will you say that it is classical angina? Classical angina when the site is precordial, or it could be substernal. What is the typical? It is heaving or constricting in nature, which gives rise to the characteristic Levine's sign. So what is Levine's sign? Clutching of the chest with the fist. Clutching of the chest with the fist. That is the Levine's sign. Radiating to the left arm along the ulnar border. Radiating to the left arm along the ulnar border. It can radiate to the jaw, or it can radiate to the epigastrium. Okay, so definitely based on the clinical history, we can think of angina as the cause of chest pain in this patient. How will aortic dissection come? Aortic dissection also can be retrosternal pain. Retrosternal pain. How it is? It is a sharp shooting pain. Almost like a searing pain, means cutting it into half. Sharp shooting pain, typically radiating to the back. Typically radiating to the back, which is likely to present with hypotension also. That is, think of aortic dissection. Acute pericarditis is a ill-localized pain. It is a ill-localized, dull aching pain, which has got typically no radiation per se, but it typically improves on leaning forward. Typically improves on leaning forward. These are the keywords that you want to look at. So when a patient has got a chest pain in the emergency room, always think of cardiac causes. So 3 important questions that we get is to differentiate classical angina, aortic dissection, and pericarditis. Considering the points given in the question, classical angina is most likely answer in our given patient. So what are the types? Classical angina. What are the clinical subtypes of classical angina? What are the clinical subtypes of classical angina? So the classical angina can present as unstable angina, or it can present as the chronic stable angina. So classical angina means due to coronary artery disease. So it can present as an unstable angina or a chronic stable angina. So what are these acute coronary syndrome? What are acute coronary syndromes? Acute coronary syndromes are nothing but the clinical presentations. They are nothing but the clinical presentations of acute coronary occlusion. They are the clinical presentations of the acute coronary occlusion, is the acute coronary syndromes. So what are the various presentations of acute coronary syndrome? The patient can present with unstable angina. Patient can present with the unstable angina. Can present with the unstable angina. Patient can present with NSTEMI. Can present with the NSTEMI or with the STEMI, ST elevation myocardial infarction. So when do you say the unstable angina is a clinical diagnosis? It is a clinical diagnosis when the patient, all new onset anginas, all new onset angina less than 2 months duration, like in this patient. If the patient is having progression in the NYHA class of symptom, NYHA class of symptom within the last 2 months, or if the patient is having angina at rest, or if the patient is having 3 or more episodes per day, or if the patient is having angina post MI within 1 month. Post MI within 1 month. You will call this as unstable angina. But in unstable angina, it is a clinical diagnosis. Here, ECG is non-specific and the troponin has to be negative because the word is angina, not infarction. Once the troponin is positive, it becomes infarction, not angina. So unstable angina is a time before the actual infarct has occurred. So what is this NSTEMI? NSTEMI is a clinical diagnosis which is biomarker positive. Patient has to be biomarker positive, but ECG may be non-specific. ECG may be non-specific, right? STEMI is a ECG based diagnosis, irrespective of the symptom. It is a ECG based diagnosis, irrespective of the symptom. So what are the drugs? I'll continue the table on the next page, same table. So continuing the table, unstable angina, there is NSTEMI and STEMI. Unstable angina, NSTEMI and the STEMI. What will be the treatment algorithm? What will be the treatment algorithm? In unstable angina, all angina, we need to start with nitrates. Nitrates to relieve the symptom. You want to start the patient on nitrate to relieve the symptom. You want to start the patient on dual antiplatelet. You want to start the patient on, load them with dual antiplatelet. So typically we give aspirin plus clopidogrel. Aspirin plus clopidogrel we want to give. You want to give statins, high dose of statins we want to give in the patient. So these 3 drugs are given to all cases of unstable angina. Along with that, if the blood pressure allows, you also want to add beta blocker and ACE inhibitor. Beta blocker and the ACE inhibitor. Beta blocker reduces the size of the infarct, and ACE inhibitor reduces the risk of heart failure. And you also give supportive therapy. Supportive therapy includes laxative and anxiolytic. Anxiolytic and laxatives you want to give the patient of unstable angina. So please remember, in unstable angina, there is no role of anticoagulation because there is no infarction yet. There is no role of anticoagulation. Harshita, I'll show you the table. Just copy this and then we'll go back. There is no role of anticoagulation in this patient. Okay. So one by one, we are going to follow the patient. There is no role of the anticoagulation. We are going to see. So taking you up. So what is clinical coronary syndrome? Clinical presentations of acute coronary occlusion are the unstable angina, NSTEMI or ST elevation MI. So patient comes with chest pain, which is typically angina. And if the patient has any one of the following, all new onset angina, progression of NYHA class, angina at rest, more than 3 per day, or post MI within 1 month, but troponin has to be negative to be classified as angina. Troponin has to be negative to be classified as angina. So taking you back up. So what is there in the symptom? Yes, correct diagnosis. Correct diagnosis. Patient is having chest pain and it is there only for 2 days duration. This is a case of unstable angina. So even though the angina is classical, this is a part of acute coronary syndrome. But TROP-T is negative. That means there is no infarction yet. TROP-T is negative, so there is no infarction yet. So what you will do? Immediately give nitrate, load the patient with aspirin clopidogrel, and give high dose atorvastatin. But what is not required? Not required is the enoxaparin. Not required is the enoxaparin, making it the correct answer. Not required, that is the correct answer, that is enoxaparin. So step by step, with each clinical vignette, I'm trying to want you to understand how the presentation occurs. So the first clinical vignette, I have given you an overview of chest pain, cardiac causes of chest pain, how are the clinical presentations of acute occlusion, and the first one we have discussed, unstable angina, clinical diagnosis, ECG non-specific, TROP-T negative, and the treatment. So to go more into the pharmacology of this treatment, that what is the role of the antiplatelet? What is the role of statin? Let us go to Thiru sir. So first we will discuss here the role of antiplatelet, the role of antiplatelets, and the role of statins in acute coronary syndrome. That is the first part of pharmacology. Over to you, sir.
Thank you for giving opportunity, sir. So wonderful clinical experience. After a long time back, I'm attending the clinical session. So interesting. Thank you, sir. So as per thing, I'm going for discussion of role of antiplatelets in the treatment of acute coronary syndrome and also role of statin. This part my part. So for a UG level, for appearing your NEETPG or INICET PG examination, what you should listen in this case is there are so many type of antiplatelets are there. Look at we have platelets. On the surface of platelet, there are so many receptors which can cause aggregation of platelet with each other, causing thrombus. For example, we have thromboxane A2 receptor, and then we have P2Y12 receptor, and then we have glycoprotein 2B3 receptor, and we have one more thing called PAR, called protease activated receptor, like that. Now, in this case of ACS, the most important antiplatelet what we are using is COX enzyme inhibitor, the so-called thromboxane A2 synthesis inhibitor called low-dose aspirin. This is very important. Low-dose aspirins are low-dose aspirin going to act as antiplatelet. How they acting as antiplatelet? Pharmacology point of view. The low-dose aspirin selectively inhibiting COX-1 enzyme irreversibly. By inhibiting selectively and irreversibly COX-1 enzyme, they are going to inhibit synthesis of thromboxane A2. Thereby, they have antiplatelet. Coming to clinical point of view, for this case, we have used loading dose. About 160 to 320 mg loading dose aspirin must in case ACS, followed by daily main dose or low dose is 75 to 150 mg. According to CMD book, 75 to 160 mg per day as a maintenance dose is called low dose therapy. Why we go for low dose being? In the low dose only, they are selectively and irreversibly inhibiting COX-1 enzyme. That's important. Whenever you're dealing with the arterial clots like acute coronary syndrome, definitely antiplatelets are important. In that, most important is we have to use low dose aspirin. Another interesting question. Just for exam point of view, I will take extra points also. Because thromboxane synthase blocker called desoxypen is one newer drug. Please note this point, desoxypen. And another interesting MC question, we got something called thromboxane A2 receptor blocker. For example, epitroban, celtroban, daltroban, and losartan. It is one old question. Which is the ARB having antiplatelet activity between losartan? Losartan having antiplatelet action by inhibiting thromboxane A2 receptor. This is another extra point actor. For your case, answer is low dose aspirin. That's important. Another interesting question. One more newer drug we have that's called thromboxane A2 synthesis as well as thromboxane A2 receptor blocker called picotamide. It is also useful for treatment of controlling platelet activity. Okay. Next interesting question. In case of ACS, we have one more special group of antiplatelet called P2Y12 blockers. For example, we have something called ticlopidine, clopidogrel, prasugrel, ticagrelor, and gangrelor. All these are P2Y12 blocking antiplatelet. Here, commonly given drug is clopidogrel. This is another common drug, but it's a pro-drug. This drug needs activation by help of CYP2C19 enzyme. So here one very commonly asked MC question, when we give clopidogrel with omeprazole, one important drug interest going to occur. Look here, clopidogrel is a pro-drug. This drug needs activation. This activation by CYP2C19. So when you give along with the omeprazole a proton pump inhibitor having the property of inhibiting CYP2C19. So this may interfere the activation of clopidogrel. So very commonly asked MC question. Next question. For controlling platelet in ACS, Apart from clopidogrel, now clinical trial shows that the prasugrel and ticagrel are more efficacious than clopidogrel. There are so many trials are telling that comparing to clopidogrel, better go for prasugrel and ticagrel. Especially ticagrel have more fastest onset action and more potent activity against platelet. So it's a wonderful drug. So currently, among the P2 vital blocker, the prasugrel and ticagrel have become more efficacious than clopidogrel, some trial finding. And for exam point of view, all the P2 vital blocking antiplatelets are given orally, exception cangrelor given intravenously. And all these drugs are irreversibly blocking P2 vital, whereas ticagrel is a reversible P2 vital blocker. All these are MCQ points. Okay. And one more point, clopidogrel also needs loading dose, 3 mg loading dose, followed by 70 mg per day. So similar to aspirin, this also need loading dose in a case of acute coronary syndrome. And it can be added to aspirin in patient with the non-ST simulation as well as an acute coronary syndrome. So dual antiplatelet, we now start talking about dual antiplatelet. So we give combination of thromboxane A2 antagonist like aspirin plus clopidogrel. It's a common dually given antiplatelets. Next. Sir asked to talk about statins. Here, when you talk about statin therapy in acute coronary syndrome, we go for a high intensity statin therapy. That is, atorvastatin, we can use 40 mg, rosuvastatin 80 mg or 48 mg. We can go for high dose. In high doses, they have very good pleiotropic property. They stabilizes the clots and preventing dislodgement of the clots. So thereby having very good role in case of acute MI as well as an acute coronary syndrome. And this slide shows what is the dose of high intensity. Here the aim is you have to reduce the cholesterol less the LDL make it less than 50, that's the aim. And here moderate intensity cholesterol lowering drug means we can go for atorvastatin 10 mg, rosuvastatin 5 mg, simvastatin 20 mg like that. Whereas mild low intensity means we can go for simvastatin 10 mg, pravastatin 10 mg, lowest 20 mg, fluvastatin 20 mg. But mostly in ACS we go for high intensity cholesterol lowering drug like atorvastatin 80 mg can be good, and then rosuvastatin 40 mg up to 40 we can go for this. But after stabilizing the patient, we have to come down the dose of either atorvastatin 40 and then gradually reduce to 20 mg because overuse may cause problem of muscle pain, myopathy, sometimes rhabdomyolysis. That's also a problem. And exam point of view, statins are important cholesterol lowering agent acting by inhibiting HMG-CoA. It's a rate limiting enzyme in the synthesis of cholesterol. They are acting by inhibiting this enzyme, thereby controlling the cholesterol synthesis. Here, one interesting point, statin not only decreasing total cholesterol, but one interesting point, statin, whenever they decreases the cholesterol synthesis, what happens? There are going to be up regulation of LDL receptor on the surface liver. So question, whenever statin decreases the cholesterol, there are going to be up regulation of LDL receptor on the hepatocytes. This may cause engulfing all the peripherally circulating LDL. So the LDL goes inside liver cells. Thereby the plasma LDL level becomes decreased. So the beauty of statin decreases total cholesterol as well as LDL cholesterol. By the way, it's a very good drug for acute coronary syndrome. Okay. And regarding this is important. It has anti-inflammatory activity and reduces the endothelial dysfunction. This is important. In ACS, there's the endothelial dysfunction. They're going to control the endothelial dysfunction, and they have antioxidant activity and plaque stabilizing property, thereby very useful in case of acute coronary syndrome. Okay. And other problem, common problem, muscle pain, myopathy, and also rarely risk of rhabdomyolysis. Okay, and then it also causing hepatotoxicity. So patient on statins should undergo periodic liver function test. But when the liver enzyme goes more than 3 times the normal, then you think of reducing dose. Otherwise, statin can be continued. According to Harrison textbook, we can continue statin even though there's a mild elevation of hepatic transferase enzyme. When the enzyme goes more than 3 times normal, then you can think of reducing dose of statin. And statin, of course, unsafe in pregnancy. This you have to keep in mind. The bile acid binding resin like cholestyramine, they are the safer drug for treating cholesterol in pregnancy. Okay. So in this case, what sir told to talk about antiplatelet and statin. Antiplatelet mean mainly we go for aspirin loading dose followed by maintenance dose, and then P2 OT blocker like clopidogrel. Or else we can go for procedural. They are a very famous drug nowadays, more efficacious. So dual antiplatelet must, and then statins are very must for treatment of ACS. That's what pharmacology background. The remaining thing I will discuss whenever sir asks me to talk about. Okay, so for this first case, we covered antiplatelet drugs and statin drug. Okay, regarding anticoagulant, regarding thrombolysis, we will talk when they come. And some more antiplatelets are missing that I will discuss later on. Wait for some time. Now I am giving the floor to sir. Sir, please, sir, please take over, sir.
Yes, sir. So it is always interesting for a physician to learn pharmacology and vice versa. So that is why this integrated sessions, I think the faculty is loving it as much as the students are. And it is always fun to understand some relevant pharmacology and pathology related to the disease, which helps us understand why something is given, why something is not given also. Great. So that is our first step, that remember that in acute coronary syndrome, when the patient has unstable angina, infarct has not occurred, and there is no role to give anticoagulation. Let's come to the next step here. So let's come to the next clinical vignette that we want to see. So what is this patient having now? So a 66-year-old hypertensive and diabetic male. Again, we are looking at an elderly male gender plus male gender plus hypertension and diabetes, has got adequate risk factors for the coronary. So presented to the ER with chest pain of 8 hours duration. So with every clinical vignette, I want to try to establish, one point which is clinical, like chest pain. Now we want to look at this, that which has worsened since the last 2 hours. So when you have a person is having chest pain for 8 hours duration and worsened since 2 hours, how will you calculate the window period? So in this case, I want you to type the answer. What is the window period? So what is actually the period that we have to count? So for the window period, how much should we count? Should we count it as 8 hours or should we count it as 2 hours? That is question number 1 to you, for which you can type your answers in due course of time. I'm not giving it away immediately. Reading further, the ECG shows the non-specific ST segment changes. ECG shows non-specific ST segment changes, but the troponin level are elevated. The troponin level are elevated, suggesting that there is infarction. Once infarct has occurred, what is required? What is required is heparin. So what is required? Aspirin is to be given. So what is the diagnosis in this case? The diagnosis in this case is NSTEMI. The diagnosis in this case is the NSTEMI is the diagnosis in this patient. NSTEMI is the diagnosis in this patient. So this becomes an indication for anticoagulation. So anticoagulation should be started should be started while in infarction. When it should be started? In case of infarction. So infarction is two types. We are going to get NSTEMI also or the STEMI also. You will have to start with anticoagulation. You will have to start with the anticoagulation you want to give. So this to be correct, we have to load the patient like in all acute coronary syndrome. You want to give aspirin. Heparin you want to give in patients of NSTEMI or the STEMI you want to choose. STEMI you want to choose. The question is between the two, C, altiplase or emergency PCI. Which one can we do? So let us read the treatment there. The treatment of NSTEMI. So NSTEMI is diagnosed when the biomarker is positive. Like in this case, troponin is positive. Tell me more about troponin. So among the biomarker, what is the most specific? What is the most preferred biomarker? What is the most specific? What is most preferred biomarker? Are the troponins. But please remember, troponins also have got disadvantages. Troponins also, can you give me few false positive causes of troponin? False positive causes of troponin important in practice are CKD, CPR and cardioversion. CKD, CPR and cardioversion you will have to take. So CKD, CPR and cardioversion. Chronic kidney disease after cardiopulmonary resuscitation or cardioversion. Troponin can be positive. Troponin rises only 6 to 8 hours after the MI. That is another disadvantage. And once it rises, it remains elevated for up to 7 days. Remains elevated for up to 7 days. We have got this answer here. So what is the treatment? Continue the column. What is the change in the treatment? Second column we are filling NSTEMI. In NSTEMI, along with the first line treatment, you want to start the patient on parenteral anticoagulation. You want to start the patient on parenteral anticoagulation. You want to start the patient on the parenteral anticoagulation. So what is the duration and why? You want to give for the first 72 hours. Why? Because this is the time when there is maximum risk of reinfarction. You want to give it in the first 72 hours where there is maximum risk of reinfarction. So that is the indication for anticoagulation. In both these cases, in unstable angina as well as NSTEMI, what is recommended? Medical stabilization. Recommended is medical stabilization and elective angiography. Elective coronary angiography should be planned after 72 hours. So in both of them, whether it is the unstable angina or whether it is NSTEMI, in majority of the cases, what you want to do? First go for medical stabilization, followed by elective coronary angiography. So here is the point. So what are the indications? Can we do anything in emergency? So I want you to learn what are the emergency indications for. I want you to learn what are the indications for early intervention. what are the indications for early intervention in a case of NSTEMI? In a case of NSTEMI, what are the indications for early intervention in a case of NSTEMI? So otherwise we wait for 72 hours. Why 72 hours? Because maximum risk of reinfarction. And also the vessel is inflamed. You don't want to do a procedure when the vessel is inflamed. After that, you want to do the procedure. Unless, of course, number one, if the patient has got life-threatening arrhythmias. A patient, MI is already confirmed. The patient is getting life-threatening arrhythmia. What is most common cause of death in post-MI patient? Which tachyarrhythmia? Is the ventricular tachycardia. So if a patient of NSTEMI is developing life-threatening arrhythmias, number two, the patient has gone into heart failure. Patient has gone into heart failure. Number three, the patient has developed mechanical complication. Patient has developed a mechanical complication. Example, papillary muscle necrosis. Patient has developed a mechanical complication like a papillary muscle necrosis has occurred in a patient of NSTEMI, or the patient is having refractory angina. Very good. The patient is having refractory angina, or the patient is having dynamic ST segment changes. Patient is having dynamic ST segment changes. Then you go for early intervention. The special indications are also diabetes and renal failure with eGFR less than 40 ml per minute. So these are the 7 indications that if present should warranty the early intervention in NSTEMI. But which is the only intervention? The only intervention allowed is the percutaneous coronary intervention. Emergency PCI, percutaneous coronary intervention, in short angioplasty, is what is recommended. The only intervention that is allowed in the patient of NSTEMI is to go for an emergency PCI. Very good. Emergency PCI. So in the second column, what I want you to write? I want you to write there is no role of thrombolysis. There is no role of thrombolysis. There is no role of thrombolytic agent. But what have we added now to our set of treatment? We have added the topic of anticoagulation. We have added to the treatment the role of anticoagulation. But there is no thrombolysis. There can be emergency PCI in select cases, but there is no role of thrombolysis in a patient of NSTEMI. Bringing us to the question. What was the question here? That when the patient has come with the NSTEMI, right? So who is the correct answer? Megha. Megha has got correct answer. It is 2 hours, never 8 hours. So from the time of last worsening, you will count the window period. From the time of last worsening, you will count the window period. Not that it is important in this case. In here, window period was not important, but just a clinical point as to how to count the window period. how to count the window period from the time of last worsening. So these two to definitely has to be given in all patients. And you also can do emergency PCI in specific indication. In the presence of specific indications, you can do the emergency PCI, but definitely not is thrombolysis. No role of thrombolysis. That is the correct answer. Not used in the management is thrombolysis. Not recommended in a case of NSTEMI. You don't want to give thrombolysis. So correct answer is C. So now we are going to add our second pharmacological point. That is, what is the role of anticoagulation? What is the role of the anticoagulation in acute coronary syndrome? So we saw the role. The role is to prevent the reinfarction in a patient who has already got the infarction. So we'll give it over to sir. So because why there is no thrombolysis in NSTEMI? There is no indication for thrombolysis, only PCI. Only PCI. You have to look at the correct actual problem and then stent. But majority of the time you want to conserve, do medical management unless there are special indication. Ana Jim Jam, that is the rule beta. Ana, that's the approach table that you have to know. Right? So over to sir for understanding more pharmacological concepts of anticoagulation, especially those used in the acute coronary syndrome. Right.
Okay, sir. Thank you, sir. Now, I think one can asking why no role of thrombolysis does it increase more emboli formation. Okay, doctor. Actually, in this case, as sir mentioned, here is a non-ST elevation MI. For this, best is antiplatelets. Along with to prevent the reinfarction, we go for anticoagulant. Whereas thrombolysis therapy can try, but they tried in clinical trial, they came with a lot of complications, lot of bleeding, that is intracranial hemorrhage, other hemorrhage. So question, when they compare the efficacy and safety of thrombolysis in non-STMI, they came to know the outcome is poor, whereas complication very high. That's why they made the guidelines. There is no role for thrombolytic therapy in case of non-STMI. That give more benefit only in ST engagement. So, sir, based on clinical trial finding, doctor. Now I am going to show the effect of anticoagulant in the treatment of acute coronary events. Okay. Now, usually when you study pathology, the clot in the artery vein mainly formed by platelets, whereas clot in the vein mainly by coagulation factor. So for treating arterial clot, again telling the first choice will be antiplatelet, like aspirin plus clopidogrel. That's the most important. Whereas vein in the clot we can try anticoagulant. Here, the purpose of using anticoagulant in MA patient, one point to prevent reinfarction. Second point, when they putting the patient ICU, they may develop some clot in the veins, DVT, other complication. To prevent that also, we are using anticoagulant. Here, most probably, we go for injectable drug because oral drug like warfarin that takes 3 to 4 days for the full benefit occur. Here, I want rapid action, so we go for parenteral anticoagulant. The most important, one is called heparin. One more thing called LMWH, the so-called low molecular heparin. All the heparin as well as low heparin, both the class of drugs are acting via antithrombin 3. By activating antithrombin 3, heparin inhibiting factor 10A and 2A mainly, whereas LMW is also acting via antithrombin 3, but they mainly inhibiting factor 10A. Here, important point, what you should know, what are the example for LMWH? See, all these are derivative of heparin. So the name should be ending with the parin. Parin, for example, enoxaparin, dalteparin, tinsaparin, not heparin, because the derivative of heparin. In this, comparing to heparin, this LMDS is more safer. That's why latest clinical trial shows instead of heparin, better go for enoxaparin. Okay, so usually for a case of ACS patient, we go for enoxaparin injection. That's the most preferred drug because it's a very safer drug. No serious risk comparing to heparin. Apart from this, we have one more group of injectable anticoagulant, the so-called, they also acting via antithrombin 3 inhibiting 10A. For example, we have fondaparinux, idraparinux, idrabitaparinux. There are some trial shows fondaparinux also can be useful for treatment of acute coronary syndrome patient. But a large number of clinical trial shows enoxaparin is the best drug for the treatment of acute coronary syndrome comparing to regular heparin. That's a clinical point. Coming to my pharmacology point, heparin is the most strongest organic acid, causing lot of complication. Can you please answer what is the common antidote for heparin? That's a very frequently asked question. We have one thing called protamine sulfate. It's an antagonist. Protamine actually alkali drug. A alkali drug antagonizing heparin acidic drug is the best example for chemical antagonism. And one more point, protamine 1 mg able to neutralize about 100 units of heparin. This is also important. Whereas for LMWH and for fondaparinux, idraparinux, we don't have specific antidote. Whereas for idrabitaparinux, we have one antidote that's called avidin. Avidin may be the antidote for idrabitaparinux. Good mega, good mom. Protamine sulfate, very good answer. Okay. Now, in a case of acute coronary syndrome, the best anticoagulant go for low molecular heparin like enoxaparin or else fondaparinux, but compared this, best is enoxaparin. But one more trial shows that before going to one more trial, I just want to show a NEETPG question. What are the important adverse heparin? For that simple mnemonic, you should know about ABOUT. Today, after attending this session, I want to study about cardiology. I want to study about heparin. Just mnemonic about A for alopecia, B for bleeding, O for osteoporosis. Very important, very important. Heparin causing osteoporosis. Osteoporosis commonly caused by steroids. Even this is also causing osteoporosis. And U for urticaria and T for thrombocytopenia. Very important. It is called HIT, heparin induced thrombocytopenia, HIT syndrome. And heparin also having hyperkalemia problem. It has some antagonistic action on RAS pathway, thereby risk of hyperkalemia also complicates heparin. This is another interesting MCQ for NEET paper. But coming to my case of clinical ACS case, for this, today we have one more group of drug called injectable direct thrombin inhibitor. Thus, one clinical trial shows we have one drug called bivalirudin. This also can be recommended for treatment of acute coronary syndrome. See, we have something called injectable direct thrombin 2A blocker, bivalent, monovalent, like hirudin, bivalirudin, lepirudin, all of bivalent drug. Monovalent drug means we have argatroban, melagatrone. The monovalent. In this, bivalirudin can be very good for acute coronary syndrome. But you maybe studied medicine book. These drugs are wonderful drugs for treatment of thrombosis in a patient who had HIT. Suppose a patient developed a complication of heparin-induced thrombocytopenia. For them to have anticoagulation, the best will be go for direct thrombin blocker like lepirudin, argatroban. Another important MC question you should know. All these drugs are undergo renal route of excretion, exception argatroban. Argatroban undergo biliary route excretion, so it is safe in kidney failure. It's important question. Safe in kidney failure. Which is the injectable direct thrombin blocker? Safe in kidney failure means go for argatroban because go through bile. And another latest one, we have injectable 10A blocker, otamixaban is under trial. It is not for ACS. So for acute coronary syndrome, the important anticoagulants are asking ADS slides. So come on, Harshida Verma, mnemonic ABOUT, about A for alopecia, B for bleeding, O for osteoporosis, U for urticaria, allergy or hypersensitivity, T for thrombocytopenia, it's called HIT, heparin induced anemia. Also risk of hyperkalemia. Okay, that's about adverse effect of heparin. But finally, in conclusion, what I want to say, for a case of acute kidney syndrome, regarding anticoagulation, the best will be go for LMWH like enoxaparin, or else next option fondaparinus. Rarely this subset can be used, but mostly enoxaparin. The purpose is to control reocclusion and also to prevent vein thrombosis, because they staying in the hospital for more than 1 week, they're lying down posture, more prone for thrombosis. For that also we can use anticoagulant. Okay, but there's no role for thrombolysis in this case. When we do thrombolysis, that will be discussed after sir presentation. Okay, now over to you, sir.
Yes, sir. Thank you. Right. So we took care of the second set of medicines. So it is very interesting that you correlate with the clinical feature, the pathology, the pharmacology, and that is the near ideal way to understand medicine. Right. So I hope you're all enjoying it. It's more clinical. It's more fun. So we have written down the indications for early intervention. So coming to case number 3. So coming to case number 3. That a 66-year-old hypertensive and diabetic male has come with chest pain of 8 hours, worsened since 2 hours, but ECG is showing ST elevation with tombstone appearance. So what is this? This is a case of acute STEMI. Patient is a case of acute ST elevation MI, who has presented within the window period of 2 hours. Who has presented within the window period of, total window period is 12 hours. Patient has come within the 6 hours. You have taken the patient for thrombolysis. In thrombolysis, the most preferred drug is alteplase, recombinant RTPA. Recombinant RTPA is the most preferred drug. Recombinant the deep tissue plasminogen activator. But 2 hours after thrombolysis, patient complains of persistent angina and ECG shows ST elevation. Which of the following is used in the management of this patient? Come on. So you will give me the answer. By the time, let me discuss this case a little more. So if I take you back to the third column that you have kept empty, so you can answer the question, and till that time, we will write down the points that we have left here. So the third clinical presentation is the ST elevation MI. Is the ST elevation MI, where you get a ECG based diagnosis. So what are the stages on the ECG? So please remember, the earliest feature is the presence of tall T. Unfortunately, they are non-specific to the diagnosis. The earliest feature in the ECG is the tall T, but that is non-specific for the diagnosis. The first specific feature, previously called as the Pardis sign, comes with the ST segment upsloping. So ST segment, there is elevation with upsloping of the segment, and that is also called as the tombstone appearance. That is also called as the tombstone appearance, that we must get familiar with. The tombstone appearance of the ST segment is the first specific feature of MI on the ECG. The first specific feature of MI on the ECG. So you will see here that there is the tombstone appearance will be present on the ECG, upsloping. So I can make it little more prominent. So just for your understanding, so we have got the tombstone appearance of the ST segment on the ECG. So what will you see? The Q wave is still small. The Q wave is still small because there is no infarct yet. It has come in the acute phase. This has come in the acute phase of MI. Within 6 hours of MI, you can get this finding. The ST segment is elevated with upsloping of the segment. So this is like the tombstone appearance. This is like the tombstone appearance that can come because of the ST elevation in the first part. Acute part, previously called as the Pardy's sign, now more famous as tombstone appearance, we can see. So what is the treatment approach for a patient of NSTEMI? We have studied. So finish this column. STEMI. What treatment would you like to offer? What treatment would you like to offer is that this is the only place where you can consider plus all that you have to give plus you can consider emergency revascularization. You can consider emergency revascularization if the person comes within the window period. If the patient arrives within the window period of 12 hours, within the 12-hour window period, you have to consider emergency revascularization. You want to consider the emergency revascularization here. That is what we want to do. So same treatment you want to give. Unstable angina, NSTMI, same treatment. But in STMI, it is the only one where you consider emergency revascularization if the patient arrives within 12-hour window period. If the patient comes within the 12-hour window period. So let us write down the protocol for the acute coronary syndrome. Let us write down how to manage the management of STEMI. We'll draw the management protocol for STEMI who has come within the 12-hour window period, like in our patient who has come within the 12-hour window period. Patient has come to you. So simple points, depends on where the patient has reached. Depends on where the patient has reached. Patient has reached a hospital with the cath lab. Patient has reached the hospital with the cath lab facility. That is very good. So patient has reached a hospital with the cath lab facility. Then what is the ideal time? Ideal time within 90 minutes. 90 minutes is the recommended door to balloon time. This should be the door to balloon time. Within 90 minutes, you must proceed for emergency PCI. Percutaneous coronary intervention should be performed in this patient. So if the patient has come within the 12-hour window period, within 90 minutes, you want to take the patient for emergency percutaneous coronary intervention. Why? Because it has got the best success in restoring normal coronary blood flow. The normal flow in the coronary. Restoring normal flow in the coronary. Because it is done under direct vision. You can see under the C-arm guidance, X-ray guidance. So when you inject the contrast, you can see that the occlusion has completely opened up. So that is why we say in practice, the first choice of emergency revascularization is to go for emergency PCI. But still in India, there are many situations when the patient has reached a hospital without the cath lab. So patient has reached a nursing home, patient has reached a primary health center. What should you do? What should you do is the question. Hospital without cath lab. So first thing you have to check is Google Map. So if the patient can be transferred within 30 minutes to a center with cath lab, shift the patient. So in the city, it is not uncommon that patient has reached nursing home, but a corporate hospital is 1 kilometer away. So what you will do after loading the medication, giving the first dose of heparin, you will transfer the patient. You will transfer the patient to the hospital with cath lab facility. But if the patient is far away, within the same time, you will go for the thrombolysis. Here it is called door to needle time. Door to needle time should be less than 30 minutes. You will go for IV thrombolysis. You will go for the IV thrombolysis you want to proceed with. The IV thrombolysis you want to proceed with. That is the what you want to do. You want to proceed with the IV thrombolytic therapy. Want to proceed with the IV thrombolytic therapy if the patient is unable to reach the center with the cath lab. Right? So in this case, the window period is 2 hours. I'm saying within 12 hours, anytime, within 12 hours, anytime. The management protocol is the same. Management is the same. So you start the patient on IV thrombolytic therapy. The most preferred drug is the altiplase. The most preferred drug is the altiplase. But the newer bolus fibrinolytics are also waiting. Bolus fibrinolytics are also waiting. Very important are the reltiplase and the tenecteplase. So especially in Western countries where the EMS emergency services are developed better, you can try this for home thrombolysis. IV 5-second bolus is to go for reltiplase and the tenecteplase. Reltiplase and the tenecteplase can be given. But the problem we face with the thrombolysis is that we cannot see whether it has dissolved the clot or not. Unlike PCI, where you can see whether the clot is gone or not, in thrombolysis, you cannot assess the success from outside. So what you have to monitor? You have to monitor the symptom. So what you look for? Number 1, you look for resolution of angina. Resolution of angina and resolution of the ST elevation you want to look for. So 2 parameters you monitor every half an hour. So every half an hour, what you tell the patient, how much is the chest pain, and repeat ECG every half an hour. So practically what I do it every half an hour. I'm going to ask the patient whether you have got relief of the chest pain and what is the resolution of ST elevation. You want to ask that. If the person has got complete relief of symptom, resolution of both within 90 minutes of thrombolysis, we call it successful thrombolysis. We call it the successful thrombolysis. So patient should have both. Patient should have no angina, ST segment returns to baseline. Within 90 minutes of infusion, you call it as successful thrombolysis. But if either persist beyond 90 minutes of the infusion, we call it failed thrombolysis. That is what has happened in this patient. In this patient, the clinical vignette number 3, the patient is going through failed thrombolysis. So what do I do? So patient is having refractory angina, in a way, failed thrombolysis. So in this patient, I want to start him on a IV GP2B3A inhibitor. GP2B3A inhibitor. Classical example, tirofiban. I want to start the patient on tirofiban and transfer the patient to the cath lab. Transfer the patient to the cath lab for what we call rescue angioplasty. Transfer the patient to a center with cath lab for a rescue angioplasty. So here we want to understand about two drugs. One, the thrombolytic agent, the bolus thrombolytic, and the very important group of the GP2B3A inhibitor, which is medically indicated in cases with refractory angina, which is indicated in patients of refractory angina in acute coronary syndrome. Along with antiplatelet, along with anticoagulant, you have got the choice of giving IV GP2B3A inhibitor. So to understand the pharmacology behind this agent, I'm going to hand over back to Thiru sir. And finally, we will complete that if after whether you do thrombolysis or whether you do the thrombolysis or the PCI, what should you monitor the patient for? What should you monitor for? We will discuss and close the session after we complete pharmacology of thrombolytic and GP2B3A inhibitor. Yes, over to you, sir.
Yes, sir. Thank you, sir. So, my dear friends, the mainstay of treatment in case of ST elevation MI will be revascularization. That is done by using thrombolytic agents. So, pharmacology part of thrombolytic agent. First of all, you should know the available thrombolytic agent. We have the older drugs like streptokinase, urokinase, and the newer drug, the so-called tissue plasminogen activator like altiplase, retiplase, and dentiplase. These are tissue plasmin activator, and they are also called clot-specific thrombolytic agent. Whereas streptokinase, urokinase are clot non-specific thrombolytic agent. Here, what most important is you have to compare the available thrombolytic agent. Here, sir has mentioned one beautiful point, that is, what are the infusion thrombolytic agent, what are the bolus thrombolytic agent, like that. Okay. Now, today we have the three most important newer drug called tissue plasmin activator, namely altiplase, retiplase, tenetiplase. They're very, very important. Okay. Here, the altiplase given initially bolus followed by infusion. So given bolus followed by infusion. So retiplase also initially bolus followed by repeated bolus injection. Whereas the tenetiplase single bolus injection. That's why sir mentioned in foreign country, even in the ambulance itself, while shifting the patient to hospital, and the shifting phase itself, in the ambulance itself, we can thrombolyze the patient by injecting bolus thrombolytic agent. So which are the bolus thrombolytic agent? Mean answer retiplase and tenetiplase. This is very, very important MC question. Whereas altiplase given initially bolus followed by IV infusion. Whereas our old streptokinase, urokinase are IV infusion therapy only. So the new two drugs can be given as a bolus injection, mean retiplase, tenetiplase, and it's a most superb single dose therapy bolus injection. Even in the ambulance itself, we can give. Okay, and then these drugs, what are the important problem? They cause bleeding. Bleeding is the most common adverse effect of all the thrombolytic agents. and all also causing hypotension, all may cause allergy, but the most important, streptokinase obtained from streptococcal origin. So it has more chance of allergic reaction. Okay, that's one thing. And the reocclusion, even after, discuss has told failed thrombolysis. That is, even after thrombolysis, the chance of reocclusion is about 10 to 30% with the altiplase, and reticulase have almost very good, no risk of reocclusion. This altiplase single dose, so can be chance of 5 to 20% reocclusions also there, possibility. So comparison, but coming to real pharmacology part will be, look here, how the thrombolytic agent works, how they dislodge the clots. For example, all the thrombolytic agents are activating plasminogen. The plasminogen is called profibrillation. By activating this, they become fibrinolysin. That means plasmin. So all the thrombolytic drugs are plasminogen activator. The streptokinase and urokinase will activate both the clot-bound plasminogen and circulating plasminogen. They call clot non-specific thrombolytic agent. Whereas the TPA, tissue protein activator, the so-called altiplase, retiplase, pentiplase, they are selectively activating the clot-bound plasminogen. They call clot-specific thrombolytic agent. Okay, and another point, as sir mentioned, within 12 hours of admission, if you do thrombolysis, very good response. There's more than 60% of the death can be minimized by thrombolysing within 12 hours. Actually, when thrombolysis within 3 hours, more than 60%, within 12 hours means 50% reduction of mortality. So as early as possible, try to do thrombolytic therapy. And next point, but while thrombolysing, you know, the most important problem, they cause bleeding. So be careful, there are some contraindications. What are the absolute contraindications for doing thrombolysis? For example, hemorrhagic stroke or non-hemorrhagic stroke within past 1 year, or marked hypertension, aortic dissection, active internal bleeding. All these are absolute contraindications for doing thrombolysis. But there are some relative contraindications are there. For example, the patient is using some currently anticoagulant, and recent invasive surgical intervention, or known bleeding diathesis, pregnancy, hemorrhagic ophthalmic condition, active peptic ulcer disease, or history of hypertension but currently controlled adequately. All these are relatively contraindications. So please go through this also. Another very important MCQ purpose of it, the thrombolytic agents are very much useful only for ST elevation MI. This is most important. And they also useful for treatment of facilitated PTCA. And one more thing, useful for pulmonary embolism, acute embolism. Of course, they also useful for TIA, thrombotic stroke, not for hemorrhagic, thrombotic stroke can be useful. But the very important question, common problem, bleeding. So you should know what are the antidote. This is again MCQ. You must know question, Anybody? What is the specific antidote for thrombolytic agent? Can you please answer? We have 3 drugs. One is called epsilon aminocapric acid. One more thing, tranexamic acid. One more thing called aprotein. In this, please note, epsilon aminocapric acid is the most specific antidote for thrombolytic agent. Even though book says epsilon aminocapric acid, tranexamic acid, aprotein, the most specific is epsilon aminocapric acid is a specific antidote for thrombolytic agent. Okay. Another very important point, what I want to tell, whenever a patient having ST-HMI, in summary, what we hope. First thing, we have to control the pain by using nitrate therapy. Even morphine can be used for controlling pain because morphine is a very potent opioid analgesic agent going to control pain. In this junction, you should know there are some opioid unsafe in case of acute coronary syndrome. There is something called pethidine and pentazocine. Even though they are opioid, even though the painkiller, they are contraindicated for treating MI pain because they may cause side effect of tachycardia. They may increase the oxygen demand, so worsens the size of infarction. So they are unsafe. So the safe is morphine. So painkiller. Other thing, very, very important, antiplatelets. MASTH means mainly antiplatelet. MA means acute coronary syndrome means antiplatelet using aspirin plus clopidogrel. And then recanalization. It is by either medical method or by surgical intervention, either by doing thrombolytic therapy or by using angioplasty. Thrombolytic, I told, streptokinase, urokinase, newer drugs are altiplase, retiplase, tentiplase. The TPS are most favorable drug nowadays. Next. Again, remember, if the patient having associated problem like hypertension or diabetes or high cholesterol, all these should be taken care of. And finally, one take message, in case of non-ST-HMI, you can use antiplatelet, you can use anticoagulant, but don't go for thrombolysis. There is no rule because the trial shows thrombolytic therapy causing more adverse effect than the benefit. So they gave the guidelines. So no need for thrombolysis in case of non-ST elevation MI. All this important. And one more point, even after angioplasty, look at this again important point you should know. A patient having ACS, you are doing PTCA, or in case MI, you are doing PTCA. Even after doing PTCA, the chances of reocclusions are there. So we put one stent. When you put stent, the stent may cause endothelial damage. To prevent the endothelial damage, in the stent, we are adding some drug. They call drug-eluting stent. Anybody wants to name some drug useful for preparing drug-eluting stent? Can you answer? The two most important drugs are one thing called sirolimus, one more thing paclitaxel. Both are useful for preparing drug-eluting stent. Sirolimus nothing but a immunosuppressant acting by blocking mTOR, mucopurine target. They also call interleukin-2 receptor blocker. Any immunosuppression, common problem, infection. They also cause infection, but specific problem of sirolimus, it may cause hypertriglyceridemia and thrombocytopenia. This is important. Which is the immunosuppression causing adverse effect of hypertriglyceridemia? Answer sirolimus important. One more drug useful for preparing drug-eluting stent is paclitaxel. Paclitaxel actually anti-cancer drug. This drug may cause adverse effect of peripheral neuropathy as well as myelosuppression. Again, even this year NEETPG question, even though patient undergone PTCA, the patient should be put on dual antiplatelet. At least for minimum 1 year, they should be on dual antiplatelet like aspirin plus P2 white blocker like clopidogrel. So dual antiplatelet must even after doing angioplasty also. Once again, we do thrombolysis, but sometimes there is chance of failure of thrombolysis. For that case, what option? For that case, we are using another important group of antiplatelet called glycoprotein 2B3A blocker. Very important. They are called parenterally given antiplatelet, the so-called intravenous antiplatelet. For example, we have abciximab, then FT-fibatide and tirofiban. These are three important intravenously given antiplatelet. Target is glycoprotein 2B3A receptor blocker. The most important indication of these drugs are after doing thrombolysis, still the patient having problem of angina. It's called failure case of thrombolytic therapy. We can use this intravenous antiplatelet. Again, one question. Name the MAB having antiplatelet activity. Mean think of abciximab. The other two drugs are FT-fibatide, tirofiban. Again, important point you should know. the abziximab undergo non-renal route of excretion. So safe in kidney failure. Whereas FT5 teriflunomide undergo renal route of excretion. So be careful in patient with the kidney disease. All this is important. And finally, for completion purpose, I want to tell one more point. We have one more latest group of antiplatelet called PAR1 blocker, the so-called protease activated receptor 1 blocker. They call oropaxib and etopaxib. They are orally given, never antiplatelet. Just for completion purpose, I told this also. Oropaxib, etopaxib are orally given PAR1 blocking antiplatelet. Anyway, for your case, thrombolytic therapy mean I discuss all the drug name, mechanism action, complication, contraindication, and also antidotes. Coming to failed cases, we discuss about glycoprotein 2B3 blocker given intravenously. Name the monoclonal antibody having GP2B3 blocker, abziximab, and other drugs are FT5 teriflunomide. That finishes complete idea. So you should know stable angina, unstable angina, MI, where to start antiplatelet, where to start adding anticoagulant, when to go for thrombolysis, where you should not use thrombolysis, all the things completely discussed. So from Goodman-Gilman and from CMDT and from Harrison, I discussed along with Dr. Srinath sir. Thank you for giving the great opportunity. Thank you, sir. Srinath sir. Thank you, sir. And thank you, my students. Read well and follow sir guidelines for the remaining portion. Thank you very much. Thank you very much.
Thank you very much, sir. This is a very fast and quick review of the very important topics of pharmacology, that is thrombolytic therapy and the GP2B3A inhibitor. So this is how we try to plan our day today. So we studied about the role of the thrombolytics also, and we also studied the role of the GP2B3A inhibitor. And as sir mentioned, the newer antiplatelet which are available orally also we need to understand. So this is how you manage an acute coronary syndrome when the patient has come to you. So if you look at the overall review, that if you have a patient with acute coronary syndrome, unstable angina, you want to start with the nitrates, dual antiplatelets, and you want to do for statins. If BP allows, beta blocker, supportive therapy. In NSTMI, you go for parenteral anticoagulation. And in STMI, you want to consider emergency revascularization. So last point we want to know is that what should you monitor after the post thrombolysis or post revascularization? Post revascularization. So whether I do an angioplasty or I do thrombolysis, PCI or thrombolysis, whichever one I choose, what are we planning to watch? We are mainly looking at the presence of reperfusion arrhythmia. We want to mainly monitor for the presence of reperfusion arrhythmia. So important question. The monitor for the presence of reperfusion arrhythmia we want to see. So practical question to end the class. All of you, I want you to answer after MI on the ECG, after you have done the revascularization. ECG shows broad QRS complex rhythm. Suppose the ECG shows broad QRS complex rhythm with regular RR interval. Broad QRS complex rhythm with regular RR interval. You tell me, should you be happy or should you be worried? So the question number 1 is whether should you be happy or whether you should be worried if the ECG monitor shows a broad QRS complex rhythm with a regular RR interval after revascularization. That's the question to end the day. Come on. So you have to tell me whether you should be happy or sad. The answer is it's not yet known whether you should be happy or sad, because The same pattern till here. Till here, broad QRS complex with regular RR can be seen with the most common reperfusion arrhythmia, that is accelerated idioventricular rhythm. Accelerated idioventricular rhythm, the AIVR. Accelerated idioventricular rhythm usually indicates successful reperfusion. Successful therapy, it will indicate. So if the patient has got runs of AIVR, then you must celebrate. Runs of AIVR, you must celebrate. But we have studied the most dreaded, the cause of death is the ventricular tachycardia. Both of them are ventricular origin. That is why both are broad QRS complex with regular RR. So to end the day, I want you to tell me, what is the only difference between the two? What is the only difference between these two reperfusion arrhythmias? Both of them are ventricular. One is very good, one is very bad. One is good, one is bad. What is the only difference? The only difference is the heart rate. Heart rate, when it is less than 100 beats per minute, it is AIVR, time to celebrate. When it is more than 100 beats per minute, you must be worried, because this is the most common cause of death. This is the most common cause of death, right? So this is how you manage acute coronary syndrome. I hope you enjoyed it. Absolutely, we enjoyed it. Thank you very much once again, sir. So time to call it a night. So good night, all of you, and all the very best for the exams, and have a good session. Chalo, bye. Good night. We cannot do PCI. We cannot do PCI within 24 hours. No, we have to wait for at least, the window period is only 12 hours. The window period is only 12 hours. Please remember. So Arnab Sen, that's the whole point, no? So window period is only 12 hours, not 24 hours. Window period is only 12 hours. And that's the exact reason why you should not do beyond 12 hours. Beyond 12 hours, there is a high risk of reperfusion arrhythmia. There is a high risk of reperfusion arrhythmias. There is a high risk of the reperfusion arrhythmia, especially the ventricular tachycardia. That is why we don't prefer to do thrombolysis or PCI after 12-hour window period. After 12-hour window period, right? So that is what we have for you today, right? Chalo. Good night, everyone.
Thank you, sir. Good night, sir.
Thank you, sir. Good night, sir.
Thank you.